bringing sepsis back. It's vasoactive shock and that's a fact. It makes your BP drop oh so fast. So grab a lactate, run the fluid stat. Tube it to the lab.
Hey everybody, welcome back to the PEMS Education video blog. I hope you're all enjoying the summer so far. Here in Arizona, we've had temperatures approaching 120 degrees, so we're all trying not to melt. I'm glad to be back with you this month talking about a huge topic in emergency medicine, sepsis. Specifically, we're going to spend some time talking about the paradigm shift from Sepsis 2.0 to Sepsis 3.0, since there have been some important changes in the way we think about sepsis in the last year. So let's get started.
Culture still. Get your sepsis on. Get your sepsis on. Get your sepsis on. Get your sepsis on.
So this month I'd like to start out by just talking about why sepsis is such a big deal and why we care about any of this. And then just take a few moments to consider the evolution of sepsis care over the last 20 or 30 years. From there we'll move into the new definition of sepsis and reflect on the pros and cons of the new paradigm of Sepsis 3.0. You may recall from prior talks that I'm a bit of a grammar freak, so this month's comic relief comes in the form of some creative new words, like the nomonym, a food that tastes like another food. Nom nom nom. What we're not going to spend a lot of time talking about are the dreaded core measures. As all of you are probably quite painfully aware, CMS developed new quality measures for the care of sepsis patients. While these are supposedly developed to promote best practice, I think most of us would agree that they can feel a little more like this. We could easily spend 2 or 3 hours just talking about the core measures, and why frankly, most of them are not necessarily a great idea. At this point, we all kind of have to play by their rules, but it's not clear how long these core measures are going to last, since there's quite a bit of controversy surrounding them. So rather than spend a lot of time talking about this, it seemed like it made more sense to spend our time together talking about how and why we have an updated paradigm for sepsis management, and how the new sepsis definition may or may not change the care of your septic patient. Illness and death due to infection have been described by physicians through the ages, and yet sepsis is still difficult to clearly define. To make it more challenging, over the years, the definition of sepsis has changed as our understanding of the disease process evolves. I'm not sure it's quite as bad as Beaker thinks, but I think I saw this meme when I was doing research for this talk, and in some ways it's not too far off. As simply as possible, sepsis is a syndrome of physiologic and pathologic changes that occurs in an organism due to an infection. That sounds great, but actually applying the definition of sepsis clinically to figure out which patients are actually septic has proved to be a major challenge. After all, it's not like there's an easily measured blood sepsis level, and there's no such thing as a gold standard for diagnosis. In the ED, we're participating in about the first 6 hours of a patient's care, so we also don't have the benefit of things like blood culture results, serial diagnostic tests, and so on, but we're under enormous pressure to identify these patients rapidly. Why all the fuss about sepsis? Sepsis is a major public health concern and is one of the leading causes of death worldwide. In the United States, sepsis accounts for more deaths than prostate cancer, breast cancer, and AIDS combined. The number of hospitalizations with sepsis have also overtaken those for myocardial infarction. The reasons for the increasing incidence of sepsis in the last few decades is probably multifactorial, likely due to the aging of the population, people living longer with chronic illnesses and indwelling devices like catheters, G-tubes, an increasing frequency of bacterially resistant pathogens, and unfortunately, decreasing immunization rates. Sepsis is also under-recognized. The public is pretty tuned into things like heart attack and stroke, and they know to come into the hospital for things like chest pain and funny neurologic stuff. But more than half of U.S. adults have never even heard of sepsis, much less when to seek medical care. Sepsis is by far the most expensive condition treated in U.S. inpatients, costing more than $20 billion in 2011 and increasing by almost 12% each year. The incidence of sepsis has been increasing for reasons we just talked about, but it's also probably in part due to better recognition and reporting. There is also recognition that after surviving an episode of sepsis, many individuals are not able to return fully to their baseline level of functioning. The financial implications of this have not really been fully explored, but resulting inability to return to work, need for family members to stop working to provide care, and the costs of extensive rehabilitation have not been well quantified. So the overall cost of sepsis on society is probably quite a bit higher than reported. In order to understand how we got to where we are today with sepsis care, we need to take a second and think about where we've been. In the 1980s and early 1990s, sepsis care was nowhere near the 4-alarm fire that we think of today. There were no sepsis bundles, no serial lactate levels, no core measures. As with many of the critical illnesses we treat, the definition and understanding of what sepsis is has evolved over time. Prior to 1980, the term sepsis was thought to refer to illness caused by bacterial endotoxins, and there really wasn't a clinical definition to take to the patient's bedside. The SIRS criteria were developed in 1991 in an effort to provide physicians with a clinical paradigm for the detection of sepsis, and that's basically what we've been using for the last 25 years. Enter Manny Rivers, whose early goal-directed therapy protocol published in 2001 rocked the critical care world. While sepsis care today is different than what he published in this paper, this was really the first major step forward in the care of sepsis patients. Going back prior to the 1990s, sepsis wasn't really something that was thought of as a major public health concern. In 1991, a consensus conference got together and developed some definitions that have shaped the way we've thought about sepsis for the last 2.5 decades. The concept of sepsis was really defined more in terms of the host's response to the infection, and the concept of the systemic inflammatory response syndrome, or SIRS, was developed. All of us have been taught to use SIRS as a tool to help us screen patients for sepsis. Unfortunately, there are a lot of problems with doing so. The SIRS criteria suffer from the problem that they were trying to make a tool that was so sensitive that it identified all septic patients. The problem with that is that any time you say high sensitivity, you nearly always have to follow that up with low specificity. The problem with such poor specificity is that only a small fraction of patients that have SIRS are actually septic. For example, nearly all seriously injured trauma patients have SIRS, but they're not septic. They have SIRS because of injury and blood loss. When you get right down to it, most sick patients, whether due to STEMI, PE, pancreatitis, AAA, overdose, or a partridge in a pear tree, will all have SIRS. What's worse, you don't even have to be sick to have SIRS. I have SIRS about 3 or 4 times a day, when I work out, run up a couple flights of stairs, and so on. Lots of people with other non-life-threatening but painful conditions, like kidney stones, are also likely to meet SIRS criteria. And just to make it even more complicated, there are lots of people with infections that will meet SIRS criteria that aren't septic. Just think back on last flu season. Basically everyone that has influenza, mono, or strep meets SIRS criteria. The majority of them don't need a huge lab workup, or for that matter, anything but a Tylenol and reassurance. And don't even get me started on all the febrile kids that come in with viral syndromes. Every single one of them meets the pediatric SIRS criteria, and it would be totally unreasonable to send blood cultures and lactates on every single kid with a fever. Naturally, as you imagine, the flip side is also true. This paper was published in April of last year and looked at the question of whether the SIRS criteria could reliably identify the population of septic patients it was trying to find. They were in 172 ICUs in Australia and New Zealand, and they screened 1,171,797 admissions to the ICUs over a 14-year period from 2000 to 2013. They found 109,663 patients that had severe sepsis, defined as sepsis and organ failure, and retrospectively looked to see which of those patients had 2 or more SIRS criteria. What they found is that 88% of them did, but that left 12% of patients, about 1 in 8, that were not identified using the SIRS definition. Now, mortality decreased in both groups over the 14-year study period as the whole concept of early goal-directed therapy got deployed, with mortality in the SIRS positive group going from 36% to 18%, and the SIRS negative group from 27% to 9%. Based on this, it does look like the SIRS positive folks were probably a sicker cohort, but mortality was still almost 10% in the SIRS negative group, and so I think the important take-home point from this paper is that 1 in 8 patients with severe sepsis will be missed by the SIRS criteria, which only goes to show how imperfect the SIRS criteria are. The way we have thought about septic patients for the last 15 years was based on a continuum of disease. We've divvied up patients along this continuum based on the severity of symptoms, and the clinician was trying to figure out where their patient was along this continuum of the disease process in an effort to interrupt progression down to the next level. What I like about this paradigm is that it reflects the fact that sepsis is not a static disease, but is rather a dynamic disease process that changes over time. We've all seen patients that looked great initially spiral down right in front of us, and I think that sometimes our current system of quality review and, frankly, blame storming sometimes forgets this concept that all disease changes with time. Basically, the entry point into the sepsis diagnosis is a patient who has an infection and has SIRS. So if we use grade school math as a platform to describe the sepsis continuum, we have infection plus SIRS equals sepsis. The next stop off on the sepsis railway is severe sepsis. These patients are sicker than patients who meet criteria for sepsis, as they have evidence of end organ hypoperfusion, such as acute renal failure, altered mental status, oliguria, yada yada yada, but who are not in frank shock. So here our equation becomes infection plus SIRS plus organ dysfunction equals severe sepsis. Last of all, the super sick patients that are in frank shock as a result of their infection are aptly termed septic shock, and hence our equation becomes infection plus SIRS plus organ dysfunction plus persistent hypotension despite adequate fluid resuscitation equals septic shock. So what changed? Early goal-directed therapy made a big decrease in overall mortality from sepsis, and it seemed like things were going in the right direction. Well, the problem is that not many EDs have the resources to do the entire early goal-directed therapy bundle. In the original Rivers trial, they had what basically amounted to a mini in-ED ICU. Their team looked like this, with an ED attending, 2 residents, 3 nurses dedicated to 9 beds. In reality, what most EDs have looks a lot more like this. And instead of having a dedicated 9-bed ED ICU, you're caring for these septic patients along with the acute coronary syndrome in bed 4, the deformed forearm fracture in room 10, and navigating the endless sea of ED belly pain. It also required special equipment, and SCVO2 sensing, central line, and blood resources, things that a small community facility may not have. Since its publication, people have been asking questions trying to figure out which parts of the early goal-directed therapy bundle are really the key elements that make the impact on overall patient mortality, and which parts are essentially the fluff. And in 2014, we got some answers. Do bros ever really end a friendship? Well, if they did, you might call it a dude-vorce. The Process trial was published in March of 2014 and was closely followed by the Arize and the Promise trials. These 3 trials might be the most important thing that has happened in sepsis care in 2 decades and has changed the way we manage sepsis. So I'm going to spend just a couple of minutes and skim through them. If you're looking for a really detailed, deep dive into these papers, I'm afraid this isn't the video blog for it, because frankly, we just don't have the time. But the Rebel EM blog and the MCRIT podcast are great places to go if you really want to get your nerd on and dive deeper into the details of each of these papers. The process trial came out on March 18th of 2014 and blew the collective minds of the critical care world. The trial was done in the United States in 31 different emergency departments. Patients with septic shock were randomly assigned to one of 3 groups for 6 hours of resuscitation: protocol-based early goal-directed therapy, protocol-based standard therapy that did not require the placement of a central venous catheter, administration of inotopes or blood transfusions, or usual care, which meant that they just left it up to the treating provider to do what they felt was appropriate without a set protocol. The primary endpoint was 60-day in-hospital mortality. They included 1,341 patients, 439 were assigned to early goal-directed therapy, 446 to protocol-based standard therapy, and 456 to usual care. Suffice it to say that overall, the randomization in the groups looked pretty similar. There were no differences between the groups in terms of initial systolic blood pressure, lactate levels, or Apache score, so the groups were pretty similar at baseline. Despite that, there were some significant differences between the groups in terms of how much fluid each group got, in this case, almost universally crystalloids, and how many got transfused, and how many got started on pressors. Based on the outcomes we saw in the process trial, there were no significant differences between any of the groups in overall 60-day mortality, which was the primary outcome, nor in important things like how many days you spent on a ventilator, how many days you were on pressors, or in total length of stay in the hospital. There was a trend towards decreased mortality in the non-early goal-directed therapy groups, but this didn't even come close to statistical significance. Let's move on to the Arize trial, which was done mostly in Australia and New Zealand and included 1,600 patients in early septic shock that were randomly assigned either to early goal-directed therapy or to usual care. The primary outcome was all-cause mortality at 90 days. They had an impressive rate of complete data, losing only 12 patients over the duration of the trial, so major props to them for that. The biggest difference between this trial and process was that they didn't have the non-early goal-directed therapy, but still protocolized arm. They just looked at early goal-directed therapy versus usual care, which allowed the treating provider to treat the patient as they saw appropriate. Again, the groups were well randomized and were very similar in regards to the severity of illness, age, systolic blood pressure at enrollment, and all of the other variables considered. However, there was a significant difference between the groups when it came to how many patients got transfused or needed pressor support. However, Arize found no significant differences between the two groups in regards to mortality at 90 days or at 28 days, nor hospital length of stay, duration of pressor support, or in ventilator days. So far, the findings in the process trial seem to be holding up. And lastly, the PROMISE trial. This trial was another RCT, but this one was done in England at 56 hospitals and randomized 1,260 patients to receive either early goal-directed therapy or usual care. The primary outcome was all-cause mortality at 90 days. As in the other two trials, the randomization worked well, and there were no significant differences between the groups in terms of how sick they were. Lactate levels, Apache scores, and baseline blood pressures were the same prior to enrollment. Again, the patients in the early goal-directed therapy arm got more pressors and more transfusions than the non-protocolized treatment arm. Despite these differences, there were no significant differences between the groups in 90-day mortality, hospital length of stay, total days spent on the ventilator, or any of the other major outcomes of interest. Now, before you just stomp off and stop aggressively treating your sepsis patients, there are a few things we need to look at in these papers. First of all, the gap between usual care and protocolized care has narrowed significantly over the last 2 decades. After all, in the Rivers trial in 2001, there was a 46% mortality rate in the usual care group, as opposed to mortality rates of 18% in the Process and Arize trials. All the patients that got usual care in all 3 of these trials still got pretty aggressive care. Back when the original Rivers trial was done, the surviving sepsis campaign hadn't happened yet, and the average septic patient maybe got a liter or 2, some dopamine, and may have waited for culture data prior to initiation of antibiotics. In these trials, the patients typically got at least 2 to 3 liters of fluid in the first 6 hours in every group and got aggressive antibiotic and supportive care. What was really important about these trials is that they showed us that the fancy central line with SCVO2 monitoring, aggressive transfusion, and some of the more time and resource-intensive aspects of the early goal-directed therapy bundle probably weren't what was making the difference in patient outcomes. It really comes down to the basics. Treat aggressively and treat early. Fill up the tank with aggressive fluid resuscitation, start pressors if the hypotension persists after you've filled up the tank, and get the bug juice in early. So, read any good books lately? Yup, it's the non-versation, when you talk without saying anything at all. Alright, now let's move on to Sepsis 3.0. In February of this year, JAMA published the first updated definition on sepsis and septic shock in over 2 decades. In 1991, sepsis was defined in terms of the sepsis continuum that we discussed previously, and this has basically been unchanged up until now. The task force was trying to differentiate sepsis from uncomplicated infections, which was always one of the biggest problems with the definition using the SIRS criteria. And the other big problem is that there's no gold standard for the diagnosis of sepsis. It's not like you can just draw a serum sepsis level and get an answer. They were also trying to incorporate more of an understanding of the role of the host's response to infection than the prior definition allowed. So they redefined sepsis as life-threatening organ dysfunction caused by a dysregulated host response to infection. Or, for those of you who liked the simple math we did earlier, infection plus organ dysfunction equals sepsis. They also broadened the definition of septic shock. In 2001, the task force defined septic shock as a state of circulatory failure. The problem with that is that depending on how you define circulatory failure, you will include wildly different patient populations, and this led to a lot of difficulty when it came to studying septic shock. Mortality rates for septic shock in one country may appear 5 times higher than the next, not because the care is any better, but because in one country, circulatory failure. They also broadened the definition of septic shock. In 2001, the task force defined septic shock as a state of circulatory failure. The problem with that is that depending on how you define circulatory failure, you will include wildly different patient populations, and this led to a lot of difficulty when it came to studying septic shock. Mortality rates for septic shock in one country may appear 5 times higher than the next, not because the care is any better, but because in one country, circulatory failure was basically the patient who was about 3 seconds from arresting, while in the other, any patient with a MAP under. Based on the new definition, a patient has septic shock when they have sepsis and, despite adequate fluid resuscitation, have a lactate greater than 2 and who remain hypotensive and need vasopressors to maintain a mean arterial pressure greater than or equal to 65. I'm going to say that one more time because that part blew my mind. Patients have septic shock if their lactate is greater than 2 after adequate fluid resuscitation. It's not your initial lactate that defines this, although I don't suggest you completely ignore your initial lactate. If the patient has a lactate of 13 before fluid resuscitation, maybe you should pay some attention to it. But say the patient has a lactate of 2.1 or 2.2. Fluid resuscitate your patient, and then check it again, because it's not the initial lactate that defines septic shock. It's the one after your fluid resuscitation that helps define this. So, remember that sepsis continuum that we talked about earlier? you can scratch severe sepsis out of that. The new definition only uses the terms sepsis and septic shock and eliminates that middle ground of severe sepsis. As for the SIRS criteria, well, anyone who's ever heard of Project Runway knows the saying. One day you're in, the next day you're out. And the SIRS criteria are now so 2015. In fact, despite the fact that using SIRS to identify sepsis is exactly what they've been telling us to do for over 2 decades, these JAMA authors write, quote, "The current use of 2 or more SIRS criteria to identify sepsis was unanimously considered to be unhelpful." We've taken severe sepsis out of the continuum, and since the SIRS criteria are out of vogue, it's time to take that out of the continuum as well. And now we're down to just the 2, sepsis and septic shock. I think the new definition does help to simplify the thought process behind sepsis care, but I do have some concerns that perhaps this kind of simplifies it too much. After all, anyone who's been practicing clinically understands that there is still a spectrum of disease, and that patients present to us at different places along that spectrum. Sometimes they come in very early in the course of their illness, but others present much further along the spectrum of disease. With this in mind, I find that sometimes it's helpful to consider that disease trajectory to help us figure out what the patient's plan of care and disposition should be. I agree that it's important to treat sepsis aggressively regardless of where you fall along the disease progression, but this simplification takes away some of those mental constructs that we have used to try and place patients on their disease trajectory. And I'm not a big fan of the way that it kind of feels like they're trying to turn sepsis into a one-size-fits-all diagnosis. Now that SIRS is out of vogue, there's a new scoring system on the block. Enter the SOFA. The task force felt that we needed to identify features that can be identified and measured in individual patients, but still provide some uniformity to the diagnosis of sepsis. Ideally, these clinical criteria should identify all the elements of sepsis, including infection, host response, and organ dysfunction, but still be simple to obtain and available promptly and at a reasonable cost. SOFA, or the Sequential Organ Failure Assessment Score, is what has basically replaced the SIRS criteria. There have been a variety of scoring systems developed to try and quantify the severity of organ dysfunction in sick patients. SOFA is the one that is the most common, and a higher SOFA score has been shown prospectively to be associated with higher mortality. So here it is. Simple and easy to remember, right? Not so much. Don't try to memorize this thing. That's why you have the internet. Thankfully, there are all sorts of online calculators and apps for your phone that will remember all of this stuff, and you can calculate it just by plugging in your patient's values. Unfortunately, the SOFA ain't perfect. This tool was developed for use in the ICU rather than the ED, and it can't be applied until after you have labs and all that stuff back. So it really isn't super helpful for us in the ED, where we frequently have to make decisions about how to manage patients before we have any test results to help guide us. And more importantly, this isn't a screening test for sepsis. The score was developed to describe organ dysfunction in ICU patients and was developed as a risk stratification tool. The idea was that you repeat this score on a daily basis to get an objective measure of the trajectory of the patient's illness. In fact, in the validation study of the SOFA score, only 28.7% of the patients had an infection at the time of ICU admission. So this scoring system wasn't developed strictly for sepsis. It was developed to predict mortality in the broader population of critically ill patients regardless of etiology. To the best of my literature searching capability, I don't believe this has ever been looked at specifically in an ED setting. The other problem with this is that there are a lot of chronically sick people out there who may be living with some degree of renal failure, hematologic abnormalities, chronic lung disease, dementia, chronic liver disease, in whom scoring becomes difficult. And in those cases, it's the trend that becomes useful, more so than the discrete score. Since the SOFA score isn't super helpful to us in the ED, what else have they got? The Q-SOFA score, also called the Quick SOFA, is an abbreviated version of the SOFA score that only uses clinical information that can be obtained at the bedside. The hope is that one might be able to rapidly and early identify patients with suspected infection who are at greater risk for a poor outcome outside of the ICU. It uses 3 criteria, assigning 1 point for low blood pressure, which is a systolic blood pressure less than 100, high respiratory rate, which is greater than 22 breaths per minute, or altered mentation, which basically is anything of a GCS under 15. The biggest problem with the movement to press forward with the Q-SOFA criteria in place of the SIRS criteria is that the Q-SOFA has not been prospectively validated, nor has it yet been validated in an ED cohort. The authors derived these criteria from an ICU population of patients known to be septic, and despite this lack of validation, they're suggesting that we apply this to the population as a screening tool. Unfortunately, it's got the same, if not more, of a specificity problem than SIRS. Now, if you meet these criteria, it sounds like you're probably sick enough that you definitely need ED evaluation. Frankly, I think these are a little silly because I don't think you're going to miss it if the patient is confused and tacky. But these patients could have DKA, or hepatic encephalopathy, or acute renal failure, or a seizure, or any number of other things that will make a person sick besides sepsis. So many systems are jumping the gun and forgetting that it's not enough to meet SIRS or Q-SOFA criteria. The entry into the pathway of a sepsis evaluation should not be whether you meet one of these criteria. First, you have to have a reason to suspect an infection, and then you apply one of these tools. Q-SOFA isn't a screening tool to identify sepsis. It was derived as a predictor of mortality. The authors describe it as a simple bedside criteria to identify adult patients with suspected infection who are likely to have a poor outcome. This is a risk stratification tool, just like the SOFA score. Applying Q-SOFA to everybody is kind of like using "Does the patient have a chest?" as the entry point of evaluation for PE, instead of using a clinical assessment to ask whether or not the patient has symptoms that might prompt evaluation for PE. You need clinical suspicion of a disease before you apply a decision tool, so please don't start using this as a triage tool. That's not what it's for. Ever wish you had actually just taken that junior high typing course? I know I wish I had, because I'm in that group of unkeyboardinated folks. Before we get into the next section, I need to put out a little disclaimer. We are now leaving the ivory tower of evidence-based medicine and entering the much murkier realm known as my opinions. As with any consensus definition, there are some problems with the new sepsis. Some of these are openly acknowledged by the authors, some are not. But I do think we need to think about some of these and be aware of the limitations of the new definition as we forge ahead into the brave new world of Sepsis 3.0. There is both some good and some bad in the new definition. One of the biggest problems with it is that while they tried to give us a better definition of what sepsis is, the definition itself is still subjective. Take this quote from the paper. What differentiates sepsis from infection is an aberrant or dysregulated host response and the presence of organ dysfunction. Okay, now tell me exactly what a dysregulated host response means. Where is the cut point between where a patient's response to an infection goes from normal to abnormal? And how exactly are we defining organ dysfunction? The SOFA score is one way of doing that, but what if the bili is normal and the transaminases are bumped? Does that count? What about a patient who's anemic, or who has a coagulopathy but their platelet count is still okay? Those sound like things that a sick patient may have to me, but they're not accounted for in the SOFA score. If altered mental status clears up once the patient defervesces, is it still dysregulated? These are questions that I don't know the answers to. And while I think there are patients that are clearly going to be on one side of the spectrum or the other, there are still going to be a lot of tweeners that end up somewhere in the middle, and based on this definition, it's not going to be clear what to do with them. Now, let's look at this statement taken directly from the paper. Sepsis-induced organ dysfunction may be occult. Therefore, its presence should be considered in any patient presenting with infection. Conversely, unrecognized infection may be the cause of new onset organ dysfunction. Any unexplained organ dysfunction should thus raise the possibility of underlying infection. This may be the most spectacularly ridiculous piece of doublespeak that I have ever encountered. What they're saying is basically, well, you seem to have an infection, and you don't have any signs of organ dysfunction, but since that might be occult sepsis, I should assume that you're septic despite the fact that you don't actually meet the definition of sepsis that we just made up. And the same thing for the flip side. But pretty much everyone who has a serious illness has organ dysfunction of some kind. If they didn't, they wouldn't be sick. This is so non-specific that it's completely useless and doesn't do anything to help you figure out who is actually septic and who isn't. Screening tools come at a cost. The more sensitive you get, the more specificity you lose. There is a threshold at which you start harming more people than you help. Look at what happened with PSA for prostate cancer as a screening tool as an example. How much harm are we doing by sending unnecessary blood cultures and treating contaminants, and by giving empiric antibiotics to people who don't need them? C. diff is no fun, and in 2011 about 30,000 people died from C. diff infections and its associated complications. And in up to 30 to 50% of cases, they got it because the patient was started on an antibiotic that was ultimately deemed to be unnecessary. I'm all for treating sepsis aggressively in sick people, but I'm not convinced that treating everybody to catch that one rare case of occult sepsis is reasonable. The authors come right out and say that they think that SIRS isn't helpful, unanimously, all 19 of them. So if that's the case, why have we seen such a decline in sepsis mortality in the last 2 decades when the SIRS criteria were exactly what we've been using? Based on the new definition of sepsis, you have sepsis when there is an infection plus organ dysfunction. Organ dysfunction is defined as a SOFA score of 2 or more, so we at least have a way to quantify that, but it's still up to the clinician to decide whether there is an infection present. The way we do that usually involves looking for things like fever, cough, dysuria, looking at the white blood cell count, tachycardia, many of which sound awfully familiar, probably because they're the SIRS criteria. So even though the authors say they're not helpful, I would argue that they're part of the physical evaluation and judgment, and that's what SIRS has always been trying to do, just quantify and standardize physician judgment. I'm not saying that it was really all that helpful to quantify it as SIRS, but despite the fact that these authors say that SIRS isn't useful, we're still going to be using the components of SIRS. We're just not going to be calling it SIRS. The authors also state that healthcare practitioners require improved clinical prompts and diagnostic approaches to facilitate earlier identification and an accurate quantification of the burden of sepsis. There has been a big push to integrate sepsis recognition into the electronic medical records we've all been subjected to. This sounds like a neat idea, a little electronic nudge to help you identify patients that might be septic. These authors suggest that clinicians would benefit from being prompted to consider sepsis in any patient that meets Q-SOFA or SOFA criteria. I would be willing to bet that pretty soon there will be EMR pop-ups that prompt you to consider sepsis in all of the patients that meet these criteria. Now, think back to your last shift. Did you get a little pop-up for all of your febrile patients to remind you that the patient might have sepsis? Or all of your tachycardic patients? Or all of your tachypnic patients? How many of those did you just click right through and ignore? This phenomenon is called alert fatigue. In emergency medicine, there has been an increasing trend to have a fancy alert for everything. Code blue, STEMI alert, stroke alert, trauma alert, sepsis alert. The problem with this is that when you alert on everything, pretty soon the sense of urgency bleeds away, and all of these alerts just become more background noise, which sort of defeats the whole purpose of having the alert. The real question is whether clinicians actually benefit from these. Sepsis mortality has gone down dramatically in the last 2 decades, well before we all had EMRs thrust upon us to remind us who to treat for sepsis. Frankly, I think the last thing we need is more interruptions and distractions in the form of QSOFA alerts. There also seems to be a disturbing lack of consensus regarding these supposedly consensus definitions. These were developed by the European Society of Intensive Care Medicine and the Society of Critical Care Medicine. They brought together a task force including critical care, infectious disease, surgical, and pulmonary specialists in 2014. Unfortunately, there were some conspicuous absences here, namely emergency medicine specialists and hospitalists. It's just bananas that they wouldn't include emergency medicine, since we're the ones who make the majority of sepsis diagnoses. So while the European Society and the Society of Critical Care are pretty happy with these, there are a few important groups who aren't so happy with these definitions, namely the American College of Chest Physicians, the IDSA, and of course, ACEP and AAEM. In fact, in May of this year, an editorial was published in Chest opposing the new definitions. It seems to me a little bit premature to redefine sepsis before you get the support of all of the major players. To take the question one step further, one might ask, why now? Despite the fact that the incidence of sepsis continues to increase, probably because of better recognition and people living longer with more chronic illnesses, sepsis mortality is at an all-time low. The process, Arize, and PROMISE trials showed that we don't need an early goal-directed therapy protocol to do this well. The SIRS criteria are far from perfect, but that's what we've been using these last 2 decades, during which sepsis mortality has seen a substantial decline. So, this kind of begs the, if it ain't broke, why fix it question. Right now, we have no evidence that creating this new definition can objectively improve patient outcomes, and until we do, we're just rearranging the deck chairs. And maybe we would be better off spending our time on measures that do improve mortality, rather than just redefining the problem. Those are some of my thoughts about Sepsis 3.0, and I'll just leave it here for now. And yes, I'm a bit of a skeptic about it, but I will happily eat a great big bowl of crow with sprinkles of "I told you so" on top of it if it turns out that the new definition does result in improved patient outcomes. We've really just brushed the surface of everything that is going on with Sepsis 3.0, so if you're interested and you want more, there are a lot of great resources out there from people way smarter than me. Here are a couple of my favorites to get you started. The EMCrit and PulmCrit blog and podcast are a great place to go. Dr. Farkas posted a great Top 10 Problems with Sepsis 3.0 that is far more in-depth than what I discussed today, and Dr. Weingart has posted interviews with both Merv Singer and Cliff Deutschman, the actual authors of the new definitions, and it's great to hear their own thoughts about how the new definitions will affect sepsis care going forward. Salim Rezai's Rebel EM blog is another one of my favorite resources for keeping up with what's new and sexy in EM, and he has some great discussion posted on the site as well. There is plenty of other talk and debate going on about this stuff, but I encourage all of you to get to know this material and take the time to dig a little bit deeper into this complicated topic. Well, that's it for this time. I hope you enjoyed this talk from the comfort of your own internest, and I look forward to talking to you again next time. Bye for now.
I'm bringing sepsy back. I tell you, source control is where it's at. Cut it, drain it, pull it, and that's a wrap. Cause if you don't, they'll die, and that is whack. Take her to back you. Breathe in that blue. She's tacky too. Temp 102. Left shift voodoo. Mr. Workup is. Check the UA. Quick chest x-ray. Give cultures too. Get your sepsy on. 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 Get your sepsy on.